So, David, I mean, that's an impressive agenda, and I think what you're really telling us is that it's not just one item, it's creating an environment in which both consumers and providers have real incentives to do the right thing, to select lower cost care alternatives, and provide them not just the incentive, but the information to be able to make those choices. And it's on both sides. So it's not just one size fits all. Can you say specifically what PBGH can do to enable that broader vision of responsibility and choice coming through in real practical changes that people would feel on the ground? Well, give me some examples.
So here are 3 examples we're doing right now in California, at least. So we took 3 areas that are high cost, high variability. One is maternity care. We have this explosion in C-section rates in California. We're getting up over 30% of our births now are C-sections. That's producing a lot of harm to mothers and babies. Our, the maternal morbidity rates are going up because we're doing so many unnecessary surgeries when people are delivering babies. Orthopedics, we have total knee and total hip replacement rates going way up for people under 65. And a lot of that is giving people great benefit, but sometimes we're using expensive technologies we don't need to be, and sometimes the intervention's not necessary. And sometimes the price is just too high. And in the area of cardiac care, I mentioned coronary stents. We've got a lot of evidence that somewhere between 30 and 50% of the stents that are put in people's hearts now, outside of the situations where they've had a heart attack, may not be necessary. And taking drugs or other treatments may be just as effective in improving people's lives. So those are 3 areas that we see opportunities. And in those 3 areas, what we're doing is sitting down with the doctors in the state here, the medical leadership and the hospital leadership, and saying, what can we do together to make sure we're using these services appropriately and pricing them appropriately. And what's happened that's very productive is, part of it, as you say, is an information flow. Okay, let's figure out what information do you need to know which cases are appropriate and inappropriate. What information should the patient have to make a decision about where to go for care, where it's more affordable, and where the results are better? Where can I expect the best outcomes for me if I go to this surgeon or this surgeon? Why don't we have that data? We should be able to collect that information and give it to patients so they can make those choices. How can we change payment so that doctors who are willing to share this information about their performance and are willing to be paid less for inappropriate care or questionable care and being paid more for good outcomes, that's what we want to get. Let's change the payment so we pay you for outcomes. We don't pay you just for whatever it is you decide to do to keep your volumes up. So there's a whole balanced portfolio of tools. Another piece of it is what we call shared decision making. How do we help the patient actually say, I could either take these drugs or I could have this treatment intervention. The benefits and risks to me, how do I feel about these, given the cost, given the potential benefit, and have the patient and the doctor talk together about what the right result is. Sometimes look at a video or look at a computer tool to help make a good decision for them. So there's a whole portfolio of tools that we think would improve care, make it evidence-based, information-based, bring cost into the equation in an appropriate way, that we're trying in these 3 areas. So in California, we've met with the physicians and hospital leadership. We have committees working. We're building registries. So we're capturing data on the reasons for the treatment in case they're not appropriate. And we're capturing data on the outcomes of the treatment so that we can see who's doing a better job. And then we're creating public report cards, if you like, to help patients understand where the care is better and more affordable.
So David, the picture I'm getting is health reform is certainly got momentum. You believe, as many of us believe, that we should be trying to build on that momentum in the positive direction of getting higher performance from our health system. You've also highlighted quite articulately the difficulty of getting high performance if you don't have tools at the level of individual patients and providers making the right choices.
Right.
Against that backdrop, what are you doing differently now at PBGH that say you weren't doing a couple of years ago, and how have you sharpened your focus to really make that reality come together?
Yeah, we're spending more time talking directly to the provider community, which is hard for our individual companies to do. It's not their day-to-day business. They have huge geographies, huge populations. They can't talk to every doctor in medical society. But we can do some of that on their behalf. So we're spending a lot of time talking to the providers, and those who are interested in creating accountable care organizations or new medical home models, we're rolling up our sleeves and sitting down with them and saying, okay, where should you put that nurse? How should you get these patients in the hands of these doctors? How do we create incentives on the employer side or the consumer side to encourage them to do the things you think they should be doing. So here's an example. We have a model that actually the Boeing company developed up in Seattle called the Ambulatory Intensive Care Unit. And the idea is, let's take people who are very sick, have complex chronic illness, they're having a terrible time, they're costing a lot of money, they're often not getting good coordinated care, they fall through the cracks because they're in and out of the hospital. Let's take those patients, figure out who they are, and make sure they get in the hands of the best doctors who really know how to take care of them, supported by nurses and case managers who really help those people not fall through the cracks, take their medications, take the tests they need to take, and get good care. So there's a mapping. We have to find the right people, find the right doctors and clinicians, and put them together. So we're doing that now in 4 locations around California, with our employers helping to provide, in effect, the patients who really need that help, and then working with the medical groups and the hospital systems to say, can you deliver this coordinated care to these people? And then let's work out a new payment arrangement to reward you for getting good results with this population. So that takes us literally around the state, talking to doctors and hospitals about how to make that happen, talking to nurses about what their job is going to be, hiring consultants, really brokering that whole relationship.
Looking ahead, what do you see the direction for PBGH over the next 3 to 5 years? And if you had to say, if we were here talking 5 years from now, what would be different? What would have changed in terms of both the strategies that you're pursuing and the action on the ground that would have taken place because of your strategies?
Well, fortunately, we're actually trying to think that through. We've spent the last 6 months or so doing a 2015 vision statement, which people can find on our website. And that describes how we think the healthcare system should look 5 years from now. So we're being very purposeful, is the first answer to your question. So we envision a time when physicians and hospitals are paid for outcomes and performance. So their incentives are aligned. We envision that time when consumers face similar incentives and have, as you said earlier, the information available to make good decisions. Our job is to put in place the infrastructure to facilitate that world. So I think over the next 5 years, we need to see the public policy tools that we've talked about lined up with the private sector tools. We need employers to be putting pressure on the health plans and on the providers to align their own economic incentives and information flows to support these objectives. We need the infrastructure of measurement. We haven't talked today about IT, but we've got to have an information environment where good information is being generated routinely and is available to the patient in their home. We want to see an environment where there's innovation. We're very frustrated that so many sectors that our members work in, our companies, many of whom are world leaders in their own space, they don't see any of that innovation happening at a similar level in healthcare. They don't see any of that thirst every morning waking up and saying, how do I deliver this diabetes care better today with a new innovative way to deliver it in the home or using a computer or using the internet. So we've got to see a shift in the way the delivery system thinks. And our job is to incentivize that economically, but also to build the infrastructure, information infrastructure to support that. So, I mean, I think our course is to take the leadership of the purchasing community, which has tremendous expertise in their own industries around innovation, economic incentives, investment, and take that energy and bring it into the healthcare system and help create an infrastructure and a set of rules and expectations that holds the system accountable for affordability and for quality. So we've got a vision for how to start that process, but we're going to need a lot of partners in the delivery system, in the health plan world, and the policy world to make that happen.